Today we will understand the PV examination and assessing the pelvis. So first of all, using all aseptic precaution, apply the antiseptic lotion and clean the perineal part. Then introduce your two fingers. The first thing you will do is to palpate. The palpate between your two fingers and the thumb. Your two fingers are inside the vagina and the thumb is outside. Between these two fingers, you will be able to palpate the muscle which is transverse perineal muscle. So palpate the tone of this muscle, transverse perineal. Then next step will be to gently press the coccyx and see whether the sacrococcygeal joint is movable or not. If it is movable, please note down that the sacrococcygeal joint, the coccyx is movable. Then you move upward and try to see the sacral hollow. What is the shape of the sacral hollow? Normally, the sacral hollow is concave. Please note down whether it is concave or flat. If it is flat, then it is assumed that the AP diameters of the pelvis will be reduced. Ideally, this sacral hollow is concave. Next, try to palpate the sacral promontory. Ideally, sacral promontory is not reachable, and the diameter between the lower border of the pubic symphysis and the midpoint of the anterior border of the sacral promontory is the diagonal conjugate, which is 13 centimeter. And if you minus 1.5 centimeter from this diameter, you will get the obstetric conjugate. So this is the diameter diagonal conjugate which can be measured clinically. Ideally, our fingers should not reach the sacral promontory. If it is reaching, that means this diameter is short. Now next step will be try to sweep between the sacral brim. The sacral brim, ideally one should not be able to swap the entire sacral brim at one go. If one is able to do, that means this sacral brim is narrow. That means the transverse diameter is less. Then next is side wall. Try to see the side walls. If side walls are parallel, ideally the side walls are parallel. But if they are convergent, again it indicates that it is a narrow pelvis. So while reporting on PV examination, the side walls are either parallel or divergent. That means the pelvic or the mid pelvis is adequate. If it is narrow or converging, that means it is small. Then next will be put your fingers, two fingers between the sacrospinous on the sacrospinous ligament. If this space, that is this ligament between the spinous and the sacrum, that is sacrospinous ligament, place two fingers. If this space can accommodate two fingers, then again it indicates adequate pelvis. If it is not able to accommodate two fingers, sacrospinous ligament, then this pelvis is, the outlet is inadequate. Next step will be to feel for the ischial spines. Try to feel the two ischial spines. one should ideally not be able to palpate the two ischial spines at one time. If one is able to palpate, that means this pelvis is inadequate. Second, you can feel the spines, whether they are convergent or sharp or they are blunt. Again, normally it should be blunt, but if they are curved inwards, this will point towards inadequate. Please remember that ischial spines, this is the most important diameter of the outlet, which is approximately 10 centimeter. So this should be measured, as one should not be able to palpate the two spines simultaneously. Then coming out, try to accommodate 4 knuckles between the two ischial tuberosities, that is transverse diameter of the outlet. If your 4 knuckles are easily accommodated between the two intertuberous space, then this is supposed to be adequate pelvis. If these 4 knuckles are not accommodated, then this pelvis is indicating that this is an inadequate pelvis. The last diameter which you will see is the angle. This is the pubic angle. Just measure them. If it is more than 85 to 90 degrees, then again it indicates it is adequate. But if it is not, then it is indicating that it is a narrow outlet.
Friends, let us understand the clinical pelvimetry, how it is done, what are the various methods. The pelvimetry can be done radiologically, like X-ray, CT scan, MRI, or optoelectronic devices. The clinical pelvimetry is done by clinical assessment. Externally we can assess the inlet and the outlet, and internally we can assess the inlet cavity and the outlet of the pelvis. This is the device which you can see is used for external pelvimetry. It has 2 arms which are placed on both the sides and try to measure the external distances. The important diameters measured through external pelvimetry are intercrestal diameter, interspinous diameter between the two anterior superior iliac spines, and intertrochanteric diameter. The external pelvimetry does not tell us about the exact status, so it is not very reliable. The clinically reliable method is clinical pelvimetry, which can be done easily bedside upon every patient. So let us learn about the clinical pelvimetry, which is a very useful assessment for all obstetricians. I will be summarizing the steps of clinical pelvimetry assessment once again, what has been discussed in the video. The first is pelvic floor tone assessment. We try to palpate the transverse perineal muscles between our fingers and the thumb and try to see the tone of the muscles. The second is we press the coccyx and check its mobility. Third is to see the sacral hollow. How is it? It is concave or flat. Then fourth is we try to assess the conjugate, diagonal conjugate. The 2 fingers we try to reach to the mid sacral promontory midpoint, and the other part is the lower border of the pubic symphysis. This distance is the diagonal conjugate, and we minus 1.5 out of it to measure the diagonal conjugate. Then we sweep the pelvic rim, normally not able to sweep more than half. If it is possible, then transverse diameter of inlet is reduced. Next is pelvic rim. It should be felt round and not angulated. Next, side walls should be parallel or divergent but not convergent. The sacrospinous ligaments should accommodate at least two fingers. The ischial spines should appear blunt normally and should not be able to palpate two ischial spines at one time. If one is able to palpate, then outlet is narrow. Remember, this is the plane of least pelvic dilation. Then comes the transverse diameter of outlet, that is called as TDO, which should accommodate 4 knuckles. If it doesn't accommodate 4 knuckles, it is contracted. And subpubic angle is more than 85 to 90 degrees. To summarize the important findings, the pelvic brim should be round, the diagonal conjugate should be more than or equal to 12.5 centimeter. The symphysis pubis should have average thickness and should be parallel to the sacrum. The sacral curve should be hollow with average inclination. The side walls should be divergent or straight but not convergent. The ischial spines should be blunt and the interspinous diameter should be more than 10 centimeters. Sacrosciatic notch should accommodate 2.5 to 3 fingers. The subpubic angle should be more than 90 degrees. And the bituberous diameter should accommodate 4 knuckles, that is, it should be more than 8 centimeters. The coccyx should be mobile and the antero-posterior diameter of outlet is more than 11 centimeters. Only under these circumstances the pelvis will be called as adequate. The abdominal method of testing cephalopelvic disproportion. Patient is placed in dorsal position with thighs flexed and separated. The head is grasped by left hand. Two fingers, the index and the middle finger of the right hand, are placed over the symphysis pubis to note the degree of overlapping. The head is pushed downward and backward. As you can see in this figure, the left hand, the examiner is grasping the fetal head, and with the right hand, two fingers kept over the pubic symphysis is trying to assess the degree or the extent of the head which has gone down into the pelvic cavity. If the head can be pushed down without any overlapping of the parietal bones on the symphysis pubis, this indicates there is no disproportion. If the head can be pushed down a little and there is slight overlapping of the parietal bones over symphysis pubis, and which is evident by the touch on the undersurface of fingers overlapping by 0.5 centimeters, this indicates moderate disproportion. If the parietal bones of the head overhangs the symphysis pubis, displacing the thumb or the fingers, this indicates severe disproportion. The method which is not accurate under following circumstances: the deflexed head, when the head is high floating, when the patient is obese with a thick abdominal wall, when the uterus is irritable. Let us understand abdominal vaginal method of pelvic assessment. It is also called as Muller-Muhlröcker method or bimembrane method. If the head can be pushed down in the pelvis up to the ischial spine, it indicates no disproportion. If the head can be pushed down a little but not up to the ischial spines, then it indicates moderate disproportion. And if the head cannot be pushed down at all, then there is a severe disproportion.